Assalamualaikum. Now I will cover the remaining part of the lecture of pleura. As we have discussed before that pleura has two layers. The outer layer is the parietal layer and the inner layer is a visceral layer. Remember here there is one rule that the outer layer of all body membranes will have the same nerve supply of the structures which are outside or which are near to them. So parietal pleura will have the same nerve supply for the thoracic wall or the chest wall, and the visceral pleura, because it is more closer to the lung or it is adjacent to the lung, so it will have the same nerve supply of the lung or the viscera, because this is visceral pleura. Okay, so the pleural layers, they are innervated differently despite being a continuous membrane, although they are continuous. See here in the diagram, the parietal pleura is continuous with the visceral pleura at the root of the lung. Okay, but their nerve supply is different. Somatic efferent nerves, okay, somatic efferent nerves will supply the parietal pleura, okay, and the parietal pleura is sensitive to pain, temperature, touch and pressure. Again I will repeat, parietal pleura will be supplied by the somatic efferent nerves. What are somatic efferent nerves here? Somatic efferent nerves are the intercostal nerves and they are the phrenic nerves. Okay, phrenic nerve and the intercostal nerves are the somatic efferent nerves which will supply the parietal pleura, and parietal pleura is sensitive to four things: pain, temperature, touch and pressure. Now, the somatic efferent nerves, as I have told you, they are intercostal nerves and the phrenic nerve. So the intercostal nerve, they will supply the costal pleura. See here, because the intercostal nerves are supplying the ribs, so the intercostal nerves will also supply the costal pleura. Costal pleura is that part of the parietal pleura which is present below the ribs and the intercostal spaces. So intercostal nerves will supply the costal pleura. Now the phrenic nerve, see here, the phrenic nerve will supply the mediastinal pleura, and the phrenic nerve will also supply the diaphragmatic pleura, okay, over the dome of the diaphragm. And there are another intercostal nerves which are lower intercostal nerves. They will also supply the periphery of the diaphragmatic pleura. Again I will repeat, the phrenic nerve, which is again the somatic efferent nerve, it will supply the mediastinal pleura. The pleura which is over the dome of the diaphragm, that is the diaphragmatic pleura. But the periphery of the diaphragmatic pleura will be supplied by the lower intercostal nerves. Lower intercostal nerves. Okay, so this is the periphery. This is the periphery for the diaphragmatic pleura. Okay, it will be supplied by the intercostal nerve, and the pleura of the diaphragm, which is above the diaphragm, will be supplied by the phrenic nerve. The root value of phrenic nerve is C3, C4 and C5. Okay, this was the nerve supply of the parietal pleura. Now the visceral pleura. Visceral efferent nerves, they will supply the visceral pleura. Visceral pleura is sensitive to stretch, okay, but it is insensitive to the common sensations such as the pain and touch. Okay, we have revised or we have learned that the parietal pleura was sensitive to the pain, temperature, touch and pressure. But the visceral pleura is sensitive to stretch only. The nerves which run in company with the autonomic nerves from the pulmonary plexus. See here, the nerves which are forming the pulmonary plexus. They are the branches of vagus nerve and some of the sympathetic branches from the sympathetic plexus. They are forming the pulmonary plexus. Pulmonary plexus is supplying the lung. So I have told you the visceral pleura will have the same nerve supply as that of the lung. So the pulmonary plexus will supply the visceral pleura. Again I will repeat, visceral pleura is supplied by the pulmonary plexus. How this pulmonary plexus is formed? It is formed by the vagus nerve and the sympathetic nerve. Vagus nerve is 10th cranial nerve. It is the longest nerve which is also supplying the viscera of our body. So this vagus nerve is supplying the lung and visceral pleura also. Now, I will say something about the pleural fluid. Can you see this diagram? This is pleural space where I am moving my cursor. This is pleural space or pleural cavity. Okay, this pleural space, it contains a small amount of fluid which is called as pleural fluid. This fluid is usually 5 to 10 ml. Okay, it is a clear fluid. What is the function of this fluid? This fluid lubricates the opposing surfaces of the visceral and the parietal pleura during respiratory movements, because lung will expand and it will go inside during respiration. So it will facilitate the movement of the lung during respiration. Okay, because the hydrostatic pressures are greater in the capillaries of the parietal pleura as compared to the visceral pleura. Okay, the capillaries of visceral pleura normally absorb the pleural fluid. Okay, it normally absorb the pleural fluid. Which one? The visceral pleura. Okay, what is important here? The amount of fluid in the pleural space. What is the normal amount of pleural fluid? It is about 5 to 10 ml. 5 to 10 ml. Now, sometimes what happens, as you can see in this chest x-ray, sometimes the pleural fluid increase. Okay, any condition that increases the production of the fluid, the pleural fluid, because it was only 5 to 10 ml, but in inflammation, okay, or malignancy, that is cancer, or in congestive heart disease, or there are some diseases which impair the drainage of fluid, because there are two mechanisms. One is the production of fluid and one is the drainage of fluid. If there is increased production of fluid or there is decreased drainage of fluid which occurs in collapsed lung, so what will happen? It will result in the abnormal accumulation of fluid called as pleural effusion. Pleural effusion. What does this term means? Pleural effusion means that there is abnormal accumulation of fluid. And this question is asked in Viva, that how much fluid will be present there, which is shown in the X-ray. So the presence of 300 ml of fluid in the costodiaphragmatic recess in an adult is sufficient to enable its clinical detection. Otherwise, if some of the small amount is increased only, so it will not be clinically detected. Okay, but if there is increased amount up till 300 ml, okay, so what will happen? It will be clinically detected. The clinical signs will include decreased lung expansion on the side of effusion. For example, here there is effusion on the left side, so lung will not expand. There is decreased lung expansion. Okay, then when we will auscultate with the stethoscope, there will be decreased breath sounds. Here there will be no movement of air, there will be no breath sound. Okay, so what will happen here? There will be decreased breath sounds, and on percussion there will be dullness on the percussion over the effusion. Okay, percussion is the procedure which is done with fingers. Okay, so either we will check that either there is air or there is some fluid. Okay, if there is fluid, there is dullness on percussion. Okay, dull sound will be heard on percussion with fingers. So these are the clinical signs which will detect that there is pleural effusion. See here, pleural effusion is a collection of fluid in the pleural space. It is increased amount of fluid. Okay, the lung is compressed. Okay, it will not expand normally, so it will be compressed, and this is pleural effusion. This is costodiaphragmatic recess where the fluid is collected, and this is pleural effusion. Now there is another term which is called as pleurisy or pleuritis. Itis means inflammation, and if there is inflammation of pleura, it will be called as pleuritis. Okay, it is secondary to the inflammation of the lung. And what is the term used for the inflammation of the lung? It is pneumonia. Pneumonia is a term which means inflammation of lung. Pleuritis is a term which means inflammation of pleura. You can see here in this diagram, this is normal pleura and this will be inflamed pleura. What will happen in the pleurisy? It will result in the inflammatory exudate coating the pleural surfaces, which cause roughening of the surfaces. The pleural surfaces will be roughened. This roughening produces the friction okay, which can be heard with the stethoscope as a pleural rub. There will be a specific sound, okay, which is heard with the stethoscope when we are doing the auscultation, and this specific sound is called as pleural rub, and this pleural rub is because of the roughening, because of the pleurisy, which is producing friction between the parietal pleura and the visceral pleura. Okay, because of the pleuritis, there can be deposition of the collagen and the formation of the pleural adhesions also. In the pleural adhesion, what will happen? See here in this diagram, this is healthy lung, this is parietal pleura, this is pleural space, this is visceral pleura. But in the pleurisy, what will happen? The reduced pleural space, so that the parietal pleura will come near to the visceral pleura. So there will be friction between the surfaces. This friction will produce a specific sound which is called as pleural rub. So this is pleurisy or pleuritis. Now there are some other terms. This is called as pneumothorax. Pneumothorax. Pneumo stands for air. Okay. So air can enter the pleural cavity from the lungs or through the chest wall. Okay. It is called as pneumothorax. This pneumothorax occur as a result of disease or injury. Disease can be interstitial lung disease, and injury can be gunshot wounds. Okay, so what will happen if there is gunshot wound here in the chest cavity? So the chest wall will be punctured and air can enter from outside. Okay, or if the lung is also punctured, the air can come from the lung outside into the pleural space or the pleural cavity. This term is called as pneumothorax. In the old treatment of tuberculosis, air was purposely injected into the pleural cavity to collapse the lung, because what happens if there is air in the pleural space, that is the pneumothorax, the lung will be collapsed. So in treatment of the tuberculosis, artificially air was injected inside the pleural space to collapse the lung so that the lung can take rest. This was known as artificial pneumothorax. Why artificial? Because it is produced artificially or it is produced deliberately. So this is called as artificial pneumothorax. A spontaneous pneumothorax can also occur. This is a condition in which the air enters the pleural cavity suddenly without its cause being immediately apparent. That is, we do not know that why air is present in the pleural space. So it is spontaneous pneumothorax. Investigation usually reveals that air has entered from a diseased lung and a bulla or the bleb has ruptured. So the lung has ruptured and air has come into the pleural space. This is called as spontaneous pneumothorax. So we have learned simply pneumothorax, then artificial pneumothorax, then spontaneous pneumothorax. Now, see here, sometimes I have told you air can enter from outside or air can come from the lung also. So what will happen? See here, wounds that penetrate the thoracic wall, that is the stab wound, they may pierce the parietal pleura so that the pleural cavity is open to the outside air. This condition is called as open pneumothorax because the thoracic cavity is open now. So this is open pneumothorax. Each time the patient inspires, this is during inspiration, what will happen? Air will come inside. Okay, each time the patient inspire, it is possible to hear air under the atmospheric pressure being sucked into the pleural cavity. Sometimes the clothing and the layers of the thoracic wall combine to form a valve. Here a valve will be produced so that the air enters the pleural space or the pleural cavity during inspiration, but it cannot exit. What will happen during expiration? This air will not exit because the valve will close. Okay, so in these circumstances, air pressure builds up on the wounded side and it pushes the mediastinum. See here, it has pushed the heart and the great vessels and whole mediastinum toward the opposite side. In this situation, a collapsed lung, see here, this lung is also collapsed on the injured side and the opposite lung is compressed by the deflected mediastinum. This dangerous condition is called as tension pneumothorax. Tension pneumothorax. Again, I will repeat. See here. See this diagram. Okay. Simply, if there is a stab wound, okay, gunshot wound, what will happen? The parietal pleura and the thoracic wall is cut. There is a opening. There is an opening in the thoracic wall. What will happen? During inspiration, air will go inside. Okay, air will go inside the pleural cavity. See, there is increased pressure of air in the pleural cavity. This increased pressure, okay, it will collapse the lung. See, it is, or if the air has come from the lung also. There are two mechanisms. Either the air has come outside from the lung, so it is collapsed, or this air which is outside the lung or in the pleural space, it is compressing the lung, so it will be collapsed. Okay, on the injured side. During expiration, what will happen? This valve will close and the air will not go outside. Okay, due to this mechanism, the collapsed lung is present on the injured side. Okay, this air will produce pressure on the mediastinum, and the mediastinum is shifted to the opposite side, which is the healthy side. But because of the deflection of the mediastinum and its structures, which are heart and great vessels, the healthy lung or the opposite lung will be compressed. Okay, this is compressed lung. This was, the right one was, the injured side was collapsed lung, and the opposite healthy was compressed lung. This condition is called as tension pneumothorax. Tension pneumothorax. So we have learned simple pneumothorax. We have learned artificial pneumothorax. We have learned spontaneous pneumothorax, in which we do not know the cause. Then we learn open pneumothorax and tension pneumothorax. These are all are the types of pneumothorax. Pneumothorax means air is present in the pleural space. Now, besides air, many other structures can also be present in the thorax. For example, air in the pleural cavity can be associated with the serous fluid, which is present in the thorax, so it is called as hydropneumothorax. Hydro means water, pneumo means air, thorax, that is the water is also present, that is the serous fluid, and air is also present in the pleural space. It can also associated with pus. If pus is present, it is called as pyothorax. That is the pus. Pyo means pus, pneumo means air, and thorax. And associated with blood also, so it will be called as hemopneumothorax. Hemo means blood, pneumo means air, and thorax. Okay, so it will be present in the pleural space. So we have learnt here three terms: hydropneumothorax, pyopneumothorax, and hemopneumothorax. In hemopneumothorax, trauma to the chest may result in the bleeding from blood vessels in the chest wall, or from the vessels in the chest cavity, or from a lacerated lung. So blood will come outside and there will be collection of the blood. Or sometimes there can be collection of pus without air. If pus was present with air, it was called as pyopneumothorax. But if only pus is present without air in the pleural cavity, this is called as empyema. Empyema. This is the pus collection in the pleural cavity. This is another term, which is pleural effusion, which we have discussed before. The presence of the excess serous fluid in the pleural cavity is called as pleural effusion. Now, all types of fluids, maybe it is serous fluid, maybe it is blood, or maybe it is pus. That is, in serous fluid, this is pleural effusion. If there is blood, it is called as hemopneumothorax. If this is pus, it is called as empyema or pyopneumothorax. They can be drained from the pleural cavity through a wide bore needle, as we have learned in a term which is called as thoracostomy. Do you remember thoracostomy, needle thoracostomy, or tube thoracostomy? Because pus cannot be drained through needles, so we have to insert a tube. So it will be tube thoracostomy. See here, this is the chest X-ray in which there is collection of pus. So this is empyema. Empyema on the right side, and the pus has compressed the lungs. This is collapsed lung. Collapsed lung. The heart will be deflected on the opposite side. So it is deflected. And this is a diagram in which they have shown the pleural effusion. See here the collection of fluid in two recesses. That is the costodiaphragmatic recess and the costomediastinal recess. These recesses are present for the lung to expand during inspiration and expiration also. The movement of the lung during inspiration and expiration. So these recesses are present. Okay, two recesses, costodiaphragmatic recess and costomediastinal recess. But sometimes if there is serous fluid present in the pleural space, this is called as pleural effusion. So what will happen? This lung will be collapsed. See here, this lung, the right lung will be collapsed. It will deflect the mediastinum. So the mediastinum will be displaced to the left side, and the left lung will be compressed also. The bronchi are also narrowed. Okay, on auscultation we will hear absent breath sounds here, because here there is no lung, so there will be no breath sounds. Okay, so this is a term which is pleural effusion.